I'm Dr. Albert Rizzo, Chief Medical Officer of the American Lung Association, and I have with us today one of our awardees of our research grants, Dr. Joselyn Rojas-Quintero, who is an instructor in medicine at Baylor College of Medicine. Her central focus in her professional work has been to understand the pathophysiology of diseases. Thank you for your time today.
Thank you, Dr. And thank you to the ALA for taking the time. This is such a great honor.
Well, thank
So
you.
let's see how this afternoon goes.
I'm sure it'll go well. Just tell us a little bit about your role at Baylor and how you then came to apply to the American Lung Association for the funding for your study.
Sure. So I arrived at Baylor 2.5 years ago. I spent first 7 years at Harvard, and my current PI, I met her there when she was an instructor there. So when she opened up her lab here, she's like, "I need you to come with me," and that's how I came here to Baylor. We've been working ever since 2015 about the basic sciences of COPD,
Mhm.
and we have branched out. And given the fact that we are trying to get the data, the necessary data to start to real talks, to make the real talks about repurposing drugs for COPD, then we reached out to the ALA to get some funding to continue with my work. The first part of the work was done with the ATS grant money, and
Mhm.
now I'm going to continue with the ALA grant money, doing the part of the methylation, and now we are going to do the metabolic reprogramming assessment of my work.
Yeah, I noticed in your information that looking at COPD, you realize that it's really a systemic disease and there's a lot of metabolic components, the muscle wasting, cardiac components, osteopenia. And it's interesting that you're repurposing meds to help the COPD patient because of the different aspects of the disease and the pathophysiology. So, can you tell us a little bit more about the science behind this?
Yes, sir. So, as every chronic disease we know, they are not really isolated. They come with a number of satellite diseases that all have a number of metabolic mistakes in common. Perhaps the biggest chronic diseases that we have known for the past 100 years is type 2 diabetes, which is the example of all the things that could come about. And metformin has been known for over 55 years. It's one of the safest drugs we have. It has all the pharmacovigilance you can find. And it's been proven not only in kids, but also adults in pregnancy. It's a safe thing that has a multifactorial aspect of its mechanism of action. It can work in, it can impact not just the liver, but the liver, the gut, the muscles, the brain. And it's not just the metabolic aspect, but also the aging aspect. So back in 2019, we were talking, my PI back in Harvard and we started talking about how we can reverse the aging effect that we see in COPD. We can talk about anything that has to do with age deterrent or trying to turn back the clock. And when you talk about turning back the clock, then you go into the land of cancer and metformin. And so we thought, well, what if metformin really helps just to prevent the aging aspect of the alveolar epithelial cells we see? So we did the pilot study, which is in the Blue Journal in 2021, where we gave mice metformin after being exposed to cigarette smoke. And these animals are actually protected from emphysema, from airway remodeling. And quite impressively, we found that the telomeres of the lungs were actually prevented from losing its length. So we thought, okay, so there is more to this than just the metabolic aspect of it. We chose to analyze the kidneys and the muscles of these mice, and we found the same thing. Then we're like, okay, so if this is in the animals, how can we translate that into the humans? Is there anything we can try to map out from patients who have COPD and happen to have the diabetes and are taking this medication? Are they inadvertently being better because they have it, or are they actually worse, or are they the same? So we did a quantification of emphysema progression, and patients who have COPD and also take metformin for the diabetes, they have slower emphysema progression. In fact, there is data out there now that says that patients who take this drug and have COPD, they actually do better. They have lesser number of ER visits, less risk of lung cancer. So it begs the question: if I can have a drug that is safe, that is known, that is being used by at least 150 million people in the world right now that could also impact COPD in not just the long way, but in the systemic way, then this is a talk that we need to be having. The therapy for COPD patients, it's complicated. It has an issue with adherence. It's not really preventing the progression of the disease. It doesn't matter what you give, they will always reach there, just slower or faster. It all depends on their genetics and metabolisms. So there's a whole system that we still haven't figured out yet how to make our patients be better and survive better and to improve their quality of life. I'm not suggesting that metformin is the panacea that is going to fix everything in a matter of minutes, because that's not real, but it will help the progression. And in that way, we are helping the patients with their quality of life. And if if the comorbidities are actually controlled, then we can get them to have more exercise, to get improvement in their nutrition. There's a whole array of impact that can be modified. And if we talk about the aging aspect and how the acceleration of the aging of our patients can be restored, if we can restore the telomeres of these patients, that is a huge improvement in itself. We have time to try and control the function of the lungs, which is what we're focusing here. How metformin can affect the metabolism of the lungs themselves. We know a lot about the kidney. We know a lot about the liver. We even have a ton of data with metformin and the fetus, but the metformin and the lungs is very short. So our goal is to fill that gap of knowledge. That is my main goal.
And do you have a particular study that you have in progress right now, or it's ready to set up?
Yes, sir. So the first branch of the study, we are waiting for the results to come back. We expose mice to cigarette smoke, and we are going to map out the methylation signals with and without metformin. And I also have human samples with and without metformin, and we're also going to run the epigenomics, and then trying to find a matching signal, which is my theory is that it's going to be found in the switching on and off of enzymes that are related to mitochondrial function, quite possibly more focusing on fatty acid turnovers. More than oxidation is the oxidation, but also the usage of that acetyl-CoA to do something else, which would be, in my theory, it should be surfactant. In the data that we have from the animals that are being given metformin, we rescue the expression and secretion of surfactant A and D. So we are restoring not only the capacity of the alveoli to keep out, we are actually restoring the immune capacity of those lungs. So that impact it's big in its own way. Right now, we are going to start to study the specific pathway in which metformin can influence the alveolar epithelial cells of the lungs. We chose to work with alveolar epithelial cells type 2 because these are the stem cells of the lungs. They are in charge of the main aspects of repairing the lung, and they are the first one who are actually lost. The first loss we see in smoking patients is the number of AT2 cells. And we have found in mice and in humans that when they receive metformin, the number of AT2 cells is actually better, is significantly higher, and they have a better expression of key enzymes that are related to fatty acid oxidation and remodeling, like CP2-1A, FASN. We have an increase in the expression of the components of the laminar bodies. So it's like the AT2 cells are being protected from dysfunction. If we can keep these cells alive enough, repairs so that they can continue to keeping the AT2-1 cells alive because they transform and they keep the ventilation going, we are changing the landscape of our patients if we can restore the numbers. It sounds so simple because it really sounds so simple. But if we can restore the numbers, the alveoli can be repaired. And if we give them time, the alveoli can be restored. That is the goal. I fully believe that we can find simple solutions to complicated questions. COPD is a complicated disease. It's multidimensional. It's not just the lung, it's every organ. It's not just the patient, it's the entire family. It's not the family, it's the community. It's not where you live, it's the geography. It has so many factors around it. So we have to be able to find a simple solution, not simple that is cheap, simple that is effective. That is how I fully believe that we can fight this. And so repurposing a drug that is known, that is safe, that has all the data you can have. We just need to fill in the gaps, and we need to try to find a way to find our pathway to a trial so that we can really test it and we can really find which patients will actually be better with. Are we talking about the low flyers that are
Right.
at 29 years old? Are we talking about the goal 1 COPD patients? Are we talking only, goal 2 below it? Is it just the smoking patients? That part I do not know because I have no data with that. But I do believe that we need to find simpler things if we have them at hand.
Absolutely right. I think finding a modifying agent for COPD can go a long way for not just the patient, but you're right, the family and the community and society as a whole. So I really thank you for the work you're doing in this field. I know it's early on, but you're starting down a path where a lot more work has to be done. And
Yes,
again,
sir.
thank you for applying to the ALA for your funding, and we wish you the best of luck in this research.
Thank you.